Good morning. We are now live on YouTube. My name is Isabel Germano. I am the chair of the AANS CNS section on tumors, and it is my great pleasure to co-host this symposium today together with the World Federation of Neurosurgical Society, the Neuro-Oncology Committee, and that is chaired by Dr. Samuel Morsi, and he will speak in just a minute. I will take the opportunity to share just one slide or two to welcome first our panelists. As you can see today, we have a fantastic cadre of experts that will show with us their knowledge on glioblastoma. And just in the way of introduction, right? So why are we keep having these glioblastoma days? First, let me just give you one word on our organization. Our mission is to provide a forum for education, research, and advocacy for patients with brain and spine tumors. Our organization is actively involved in coordinating activities and programs related to brain and spine tumors, including clinical trials, research, and education. And today is really a very good example of an education activity that we do jointly. The brain tumor community is very well aware that we have months that are dedicated to brain tumors. In the US, that month is May. In the UK is March, and in other countries might vary. But we all join together internationally, globally today on celebrating the Glioblastoma International Day. And why is that? The reason is because we feel that this disease, which is the most common glioma, is also the one that is the most aggressive and the most challenging. And therefore, with that said, I'm going to hand it to Dr. Sameh Al-Morsi to continue on with the introduction of the WFNS Neuro-Oncology Committee, as well as our speakers. Thank you, all of you who joined us, and thank you, all of you who will listen to this as we move along. And Sam, you're muted, so you need to unmute yourself.
Thank you, Professor Isabel, for this introduction. And thank you all for joining us in Glioblastoma Awareness Day. Glioblastoma is still a mystery, and we are trying to find some clues to make the best management for our patients. And now we will start our session by Professor Yokoda. Please start sharing your screen. Thank you.
Thank you. So let me start sharing. I think you are seeing. Okay, let me share again. Sorry. Okay. Now it will go. Okay, so let's start. Sorry. New computer, completely crazy. But okay, so thank you for the invitation to participate on this Glioblastoma Awareness Day. My topic is the current minimal neuropathology standards for glioblastoma and this new WHO 2021 era. I have nothing to disclose. And I have 4 main points to bring to you today. The first one is what is new in this classification, the essential diagnostic criteria, molecular signature, and new diagnostic technology, and what is the potential impact of these new classifications. Just reminding everyone in the audience that we are talking about the 5th edition that was released in 2021 of the WHO Blue Book for the central nervous system. So let's start by the current definition of glioblastoma. So glioblastoma is a diffuse astrocytic glioma. It needs to be IDH wild type and H3 wild type. Having said that, this means it doesn't harbor the IDH mutations or the H3 mutations. And this is very important because it draws a line between the old astrocytomas IDH mutant that can have also the same histology, but they are mutant. So it has completely different overall survival and prognostication. And also draws another line between the H3K altered diffuse midline gliomas as well. So diffuse astrocytic glioma, IDH wild type, H3 wild type, and then one or more of the following: microvascular proliferation, necrosis, third promoter mutation, EGFR amplification, and chromosome copy number alteration, which means an extra 7 and a loss of 10. So you can have like trisomy 7 or monosomy 10. So by these current standards, you can diagnose glioblastoma only based on the microscopy if you fulfill these criteria highlighted by the red arrows. But much more, currently we are using an integrated approach that combine the histology and the genetic studies. And we usually use the NGS, the next generation sequencing here in the US. But the EGFR amplification can also be detected by other types of testing, such as FISH. Okay, just to highlight the infiltrative pattern or the diffuse pattern that we refer to. So here you have this neurons, which is like this larger cells, and a lot of infiltrative background, which is the tumor cells, also with some mitosis here. So this is the infiltrative pattern that we were referring to. And these three pictures that I bring here was considering, and is considering up to this day, the grade 4 morphology criteria. So it is pleomorphism and mitotic activity, necrosis. In this picture, you can see very nice pseudopalisading necrosis and microvascular proliferation. You have this increased endothelial proliferation of the vessels, some with the glomeruloid kind of morphology. So if you have this and the IDH is not picking up any mutation, you can call it a glioblastoma. But there is one caveat that the current classification brings. If the patient is less than 55 years old, then the IDH status needs to be confirmed by NGS. Why that? Because the current IHC picks only one type of the IDH1 mutation, which is this R132H. And there are 5% of patients that have another type of mutation, like the R132C, for example, that can only be picked up by NGS. So if your patient is less than 55, you cannot call it only based on the morphology. You need to wait on the NGS. And then overall, if you have a tumor that looks like this, very bland, you have some atypical infiltrating cells, and I know it's infiltrative because I have seen some neurons here. So few infiltrative glial cells, atypical. It was enough for us to send it to NGS, and then it came back with a third promoter mutation. So by the morphologic criteria, it doesn't reach the old GBM patterns, but the current criteria with molecular definition, it does reach. So this was a glioblastoma. And before we used to call this molecular glioblastoma, now you can just get rid of the molecular and it's a glioblastoma like the other ones. In this case, I just put here the radiology because radiology was so early, it didn't have like the heterogeneously enhancing component that we usually see in advanced states. And another thing that the WHO, the new book, brings, the term multiform was no longer recommended as part of the terminology. So currently what we say is glioblastoma, IDH wild type. So this is the name and last name of the tumor. And you don't have more glioblastoma multiform. But it's still important to remember that we have several subtypes in morphology of the glioblastoma. So first one here, as you can see, it's the primitive neuronal component, which is the small blue cell tumor. And also you have here like small cell glioblastoma, and as opposed to the giant cell glioblastoma when you have this multinucleated giant cells. This one here is very rare, granular cell glioblastoma. It seems like a granular cell tumor, but it is a glioblastoma. And the old gliosarc, in the beginning of times, we used to think that this was a collision tumor, but now with molecular studies, this was highlighted as part of the glio component. So within the glioblastomas, you can have mesenchymal-like stem cells that will end up giving this differentiation into bone, and sometimes very rarely into muscle, but much more often chondroid-looking areas. So in the past, it was called gliosarcoma. Now we call it glioblastoma with sarcomatous features. And usually the pathology will put in a comment that it was the old gliosarcoma tumor. But it's not a different entity anymore. It's just part of the subtypes of morphology of glioblastoma. This one here is very rare, adenoid formation. You see these cords of epithelioid tumor in this microcystic background with some parts of a mucinous background. And one that I want to highlight here that can be very challenging is the epithelioid glioblastoma. So the epithelioid glioblastoma sometimes look a little bit circumscribed, but you still see some cells like escaping through the brain parenchyma. And it harbors the BRAF V600E. Why it's challenging here, I bring a case that we had to review some time ago. And this case was read 10 years ago as an epithelioid glioblastoma, but as a 10-year GBM survivor is something rare, the clinical team was like, could you review based on the current classification? So tell us, what is this? So for these types of challenging, now we are using what we call the DNA methylation classifier or methylation profiler, which is studies of several tumors based on the epigenetic signatures. So the tumors can have very different heterogeneous genetic makeup, but epigenetic methylation pattern will mostly be the same. As you can see here, this cluster of glioblastoma IDH wild type is far away from the astrocytomas IDH mutant, and they were confused before just based on morphology. And here in the corner, there is this is a series of 343 tumors, and you can still see that the methylation profiler was able to distinct the glioblastomas IDH wild type from all the others IDH mutant, and including between the IDH mutants, the oligos and astros low grade and high grade. One thing that the new classification brings that is important to highlight is the calibration score. The threshold needs to be set at 0.84 or 0.90. Why is it important? Well, now in the US, this is still in research process, meaning we can access this type of testing for our patient, but it's not FDA approved and with well-established roles for commercialization. So you need, as a clinician, like to be aware that if you receive a classification score less than 0.5, it's not really accurate. It will just cluster with something else. So this is very important. So that old tumor that they ask us to review, it cluster with the PXA. And this is very interesting because the epithelioid glioblastomas are a particular entity in the methylation profiling because it can clusters with 3 different types of GBMs. One was the PXA, which here is highlighted by the survival curve in yellow. The other is the RTK GBMs in pediatric population, survival curve in red. And the other one is the one that we were calling 10 years ago, the GBM wild type epithelioid subtype. So as you can see, it's very different, the survival curves. And this is why when epithelioid glioblastomas clusters with the PXA, we will call the tumor a PXA and not an epithelioid glioblastoma anymore. So what is new in the classifications of glioblastoma? Glioblastomas are all IDH wild type by definition. They continue to have morphological subtype, but not recommended the terminology multiform anymore. Epithelioid glioblastoma with BRAF V600E can be a challenging diagnosis. DNA methylation profile can be helpful in challenging cases. An early infiltrative lesion can be a glioblastoma if it matches the molecular definition. Again, just to highlight the molecular signature, if you have one of those in an infiltrated H3 wild type, IDH wild type, it is a glioblastoma. So what is the potential impact of this new classification? It separates completely from the IDH mutant astrocytomas grade 4. It recognizes molecular landscape and genetic identity of glioblastomas and correlates with their clinical outcomes. It keeps the MGMT methylation as an independent prognostic marker for longer overall survival. And this is important to highlight the different. GMT methylation is one test, and DNA methylation classifier is a completely different test. They both have methylation in the name and can get clinicians confused when they start dealing with glioblastoma. But the DNA methylation classifier is new, and it can have potential for new discoveries when you have something with a specific mutation that is not clustering with the other subgroups. With all this, this new classification, we hope that it will improve prognostication and potentially help to optimize clinical trials in terms of inclusion, exclusion criteria, and make us better, diagnosticators for our GBM patients. So this was all that I have to bring for you today. I think most important thing is the molecular signature. This is the most new thing of the new classification. Thank you.
Thank you so much for this great talk. We have one question from the audience asking, what is the difference in a prognostic difference in GBM with a sarcomatous change?
Yeah, it's a little bit more aggressive. It will not respond very well to the initial therapy, radiation, and temozolomide. So usually the clinicians just start with everything they have when they have a sarcomatous component. So it's a little bit more dismal than a regular glioblastoma.
Thank you so much. I think we're going to move on with the next talk by Professor Eckhard Kasper, who's serving as our co-chair for global neurosurgery within the AANS CNS section on tumor. And today we'll share his experience with preoperative images to guide maximal safe resection. Ek?
Yes, thank you for having me as part of this program. I'm happy to be here and try to give you, give me one moment. I need to click on the next. Can you see my screen? I want to give you an overlook how we decide on preoperative, perioperative imaging to accomplish an effective and maximally safe resection, and how we strategize for this particular disease, glioblastoma. I have nothing to disclose. I want to take you through diagnosis and imaging for glioblastoma and how we do it in neurosurgery in my center. I want to tell you briefly about a brain tumor program and why we recommend that this is done at all centers in a multidisciplinary setting and not alone. And I want to give you 9 case vignettes for a successful practice and help patients understand why not every case gets the same imaging and why not every patient has the same surgical strategy. And for those who are interested, this can be downloaded from the internet. We have summarized this in a good book chapter that takes you through pre-surgical and surgical planning. So I think all patients should be assessed by a brain tumor team because any strategy is best developed as a team. In many centers in the US, we have set this up as a one-stop shop, which means patient-centered care flow. It's really good if there's a morning conference once a week to review all the material, and that the patient then is seen after the conference by the entire neuro-oncological team. There's usually an assigned nurse practitioner in our center that is the guide for the patient throughout the journey with this disease. And then we pull every subspecialty doctor into the room of the patient. And all doctors that need to remain involved in the care get extra time, and the patients can talk to the entire team as needed. And in our center, we have a pager. We're 24/7 available if patients at home suddenly have a change, need to come in. It's the same team that takes care of the patients. Our Brain Tumor Center is a joint center with the Dana-Farber Cancer Institute in Boston, and we have put together this comprehensive tumor program. Every patient gets a brain tumor protocol handout, and they are discussed as a team at a roundtable discussion. And then we have subgroups in case we want to break out for a skull-based group, a pituitary group, which doesn't apply to this particular set. Now, what's my imaging algorithm for a typical scenario? You see this in the red box below. Most patients come to us as non-incidental findings due to some new symptom onset, whether it's headache, nausea, vomiting, dizziness, seizures. A patient comes to the emergency room, and we consider all patients surgical until proven otherwise, because we do need a diagnosis. And for all patients, we try to obtain pre-surgical MRI scans, CTA and CTV scans, and if at all possible, functional imaging if it's a left-sided lesion or a lesion near an eloquent area. And I'll show you some examples of that in a moment. In the recurrent setting, we also get perfusion studies, MRV or CTPs, and in rare cases, we get angiograms. We use the whole array of neurosurgical and neuroradiological imaging that is available on the market. And this is not a disease you want to save on because you want to accomplish safe resections. And sometimes you need each of these technologies to answer a particular question. Best operative planning, in my mind, contains navigated imaging. So all patients undergo pre-surgical MRI scan for intraoperative image guidance, which means we are no longer resecting without knowing where we are during the case. If you can, you obtain 3D surface rendering for best entry points or to make resections based on extent of the lobe. And we get functional imaging whenever necessary to help our patients to avoid structures that carry higher morbidity. Here, for example, you have a patient with a motor strip posterior dislocated at the infiltrative margin of the tumor, and I'll show you in a second some examples. I've also, in the last 10 years, integrated pre-surgical DTIs and functional imaging in essentially every case, because we can now image where the fiber tracts run in the brain, and that really helps you understand, can you resect the lesion that displaces a fiber tract, or do you need to stop at a certain margin? Even if it may be a subtotal resection, you want to preserve functional integrity of the patient, and that has greatly enhanced our patient's outcome. Now I want to take you through some cases and distinguish in a sort of unusual way between simple and not so simple cases. From a resection perspective, this is a simple lobar right frontal GBM. The patient came to the emergency room with this right frontal lesion that was well demarcated on CAT scan, but you see on CTA, there's a margin of vessels that is partially displaced to the opposite side, pre-surgically flare. You see a lot of infiltrative tumor margin, but the contrast enhancing part of the active tumor doesn't have the same extent. So this is a patient that we take to surgery. What's our resection strategy here? We perform a lobectomy. We do not just perform a resection of the contrast enhancing portion. It's perfectly safe to take out the entire frontal lobe, and you resect posteriorly until you meet the next important level, which is the internal capsule here in the basal ganglia. So this patient doesn't have a chance for a resection postoperatively that creates a margin, because we know from Fred Barker's studies in the 90s that most of the patients recur within a 2 centimeter of your resection margin. So ideally, would take out all flare imaging, but here we took out the lobe. This is a similar lesion with a what I call simple lobar right occipital GBM. Again, you see the lesion not well demarcated on pre-surgical CT scan. On CTA, you see the vessels are hypervascular. The tumor is well demarcated on post MRI scan, post-contrast MRI scan. And although this tumor is buried inside the occipital lobe, there's really no benefit in leaving a resection margin medially and preserve this area, because most of the recurrence will happen in this infiltrative margin. So again, what we do is a lobectomy to remove the tumor with all its visible components. We got very clean resection margins, and we had an excellent outcome in this patient with a minor compromise. The patient needs to accept that they will have a visual field defect if you take out the occipital lobe, but you gain functionality and survival. Now, this is a more complex left frontal tumor. You can see the tumor showed up in multiple contrast enhancing spots. The lesion sits inferior frontal and it sits posterior to language. So again, post pre-surgery, we got a functional MRI scan to make sure we are not violating our language area. CTA pre-op showed mild hypervascularity, was not concerning, and we resected the left inferior frontal lobe in this patient to take out all contrast enhancing tumor in all 3 of these lesions as a single block. We did not try to do a lesionectomy one by one. We took out the next sulcus above and below, and we achieved an excellent inferior lobectomy with good local control rates. Now, this is a slightly different lesion. It's a right-sided temporal lobe GBM that I still consider simple. The patient was left-handed, was bilingual, and The patient was initially seen at an outside hospital with this non-contrast enhancing lobe on the right side. They felt this was a low-grade glioma, and the patient did not feel there was an urgency to follow up. And then a few weeks later, so the initial scan was on pre-Christmas, and the patient took some time to be seen post-Christmas. They didn't want to disrupt their holidays. The patient already started to show some contrast enhancement on the next MRI scan. We then showed 4 weeks later there was suddenly valid and avid contrast enhancement anteriorly, with the second flare abnormality developing posteriorly, but the lesion was very well demarcated on flare imaging. We got pre-surgical fMRI scan because of the bilinguality. The patient did not have a right-sided lingual compartment. The patient was hyperperfused on pre-surgical CTP and CTA. So what do you do with this patient? In this patient, I felt safe to do a lateral temporal lobectomy, reaching down to include all flare abnormalities, but not breaching into the ventricle. And we were able to get a successful resection of this patient with, again, a visual field compromise, because you do take out some of the fibers wrapping around the ventricle, but no other morbidity associated with this approach. Now, flipping back to the left side, again, a left-sided temporal lobe tumor, still considered to be rather simple because it sits in the anterior temporal lobe. Patient presented with a seizure disorder to the emergency room, pre-surgically fMRI and TTI, and all the scans were obtained. Large flare abnormality, but very focal contrast enhancement with astonishing hypervascularity. So we got the pre-surgical imaging scans and also obtained a DSA in this case because my colleague in radiology was concerned there could be an AVM associated with it. It wasn't an AVM, it was a dual supply. So this tumor did steal vascular supply from the ICA as well as from the external supply through the middle cranial fossa and the facial supply, which was surprising to us. But there was dense tumor blush on both of these angiogram runs, and we decided to do an anterior lobectomy and take off the vessels early on as we entered the middle temporal fossa. So this was a successful lobectomy with early vascular control of the supply to the tumor, which changed my surgical strategy, but we got away with an anterior lobectomy on the left side, not violating language. Now, in the recurrent setting, this is different. This is a recurrent left temporal glioblastoma in a patient who presented with a seizure disorder initially, had a resection done of the anterior left temporal lobe, then came back with this contrast-enhancing tumor that wrapped around the resection margin. Here we obtained MR perfusion studies because we wanted to know, is this a inflammatory or post-radiation change, possibly radiation necrosis? No. It turned out that this was a hot lesion that was contrast-enhancing on perfusion studies. So we decided to take this patient back and extend our previous lateral lobectomy to a complete lobectomy. And this was an extent of resection based on the perfusion studies where we wanted to resect all contrast-enhancing, hyperperfused, and concerning tumor. Now, this is a left-sided lesion that is not so simple because it sits in the temporal lobe, but it sits deep to the surface of the temporal lobe, and it sits lateral to the basal ganglia, so it's buried sort of in the Sylvian fissure. There's a contrast-enhancing lesion, highly concerning for malignant glioma. We got pre-surgical fMRI scans to see where's our language area, and sensory language or language processing is posterior to the lesion. Language speech production was anterior to the lesion, so we felt we had a good corridor to enter the Sylvian fissure laterally. We saw on DTI that all the relevant fiber tracts were actually displaced superiorly, or our motor tracts were displaced medially. So coming in from the side through the Sylvian fissure would not violate any of the fiber tracts. And we were able to accomplish a good resection where you see on the post-operative CT scan a nice resection margin, no bleeding. On the post-operative MRI scan, no contrast enhancing lesions. So I basically came in from a left angle into the Sylvian fissure with no DWI, no stroke associated to this lesion. So you have to be careful preserving your MCA vessels. And we accomplished a good resection in this patient who had no compromise in terms of language function. Now, some more complex lesions like this one. This is a deep-seated white matter lesion that showed up as a heterogeneously contrast-enhancing lesion with enormous hypervascularity. Initially, we were not even sure whether this was a AVM associated with the glioma or just hypervascularity. We didn't feel safe in resecting this in a microsurgical open approach, but we really felt there was a need for a tissue diagnosis. So I got a pre-surgical CTA confirming incredible vascular density. We then decided to get a DSA showing that this wasn't a true AVM, but showed enlarged veins with aneurysms on the venous side of this tumor. We got an MRS that confirmed there was a choline peak that was concerning for this being a glioma and not a vascular lesion. So here I decided just to do a stereotactic biopsy, and I biopsied a portion of the tumor that was MRS positive, so confirmed pathological tissue, but CTA negative, so no hypervascularity despite perfusion and contrast enhancement on MRI scan. So here we just used all the technology to get a safe biopsy in a highly vascular lesion. And with the tissue diagnosis, we felt we could offer this patient post-operative radiation chemotherapy, and the patient did reasonably well, besides the fact that we did not resect this tumor openly. And last case is this one. It's again a multifocal glioblastoma that sits deep in the left-sided hemisphere as a superior satellite in the frontal lobe, wraps around the ACA and MCA junction. I felt it was not smart to resect this tumor because there was another focus lateral in the language area. I felt this patient would not be served with a subtotal resection of this focus only. So this is a tumor where imaging showed us multifocal disease with involvement of eloquent areas would create too much morbidity. So we decided not to go for an open resection. Oops, I'm missing the post-op images, I'm sorry. And we did a stereotactic biopsy and offered this patient radiation chemotherapy, and she did surprisingly well, surviving a year and a half based on that alone. So as a summary, I wanted to tell you again, what is our strategy for a safe resection in non-incidental findings of symptomatic patients? So these are the typical patients that show up in your emergency room. They got imaged. We use in all patients MRI imaging with and without contrast. We try to obtain FLAIR images for navigation to do a maximum resection of all infiltrative tumor portions. I do obtain in all cases CTAs. If the patient is a right-sided frontal lobe, I do not need functional imaging, but if anything eloquent is nearby, like left-sided language, vision, or function, like motor function, I get additional fMRI scans to show where's the functional part of the brain. I may get perfusion studies in the recurrent setting, and in rare cases, we add in DSA for vascularity and MRS for definition of eloquent and pathological material. So I hope that that gave you some overview of how a neurosurgical team plans resections in a safe way, and then tailor your surgical approach based on the images available. And I want to conclude at this point.
Thank you so much, Ak. This was fantastic. We have a question from the audience asking in a basal ganglia tumor, how much do you resect? Just a very brief answer because we're a little over time.
Simple answer would be, if you cannot resect 2/3 of the tumor, don't even try, because I think the wait time you need post-surgery that the patient recovers from an open resection will allow the residual disease to grow back to the original size. So my goal is, hope for a 90% resection. Ideally, every percent makes sense. The more you can take out, the better the patient will do. Don't do it if you can take only half of the tumor.
Excellent. Thank you so much. And with that said, we're moving on to Professor Michael Ivan, who is here today representing the WFNS and sharing with us his experience on advanced surgical tools to improve surgical management of GBM. Michael, thank you.
Great, thanks. Can you guys hear me and see my slides?
Yes to both.
Okay, great. So thank you so much for your invitation. It's really an honor to be talking amongst such world-renowned experts internationally with this group. There's been some great information so far. I was asked to share a little bit of some of the advanced surgical tools to improve surgery for GBM, both current and then also kind of a little bit of wet your tongue for future kind of innovation that may be happening. So here's my disclosures. No question, there's a tremendous amount of evolution and innovation going on in brain tumor surgery. And when we kind of look at the hype cycle for technology and adaptation, you could plot a lot of kind of this technology on this curve. And so we have the well-established things that we've heard about already: navigation, microscope, intraoperative navigation. And then we have some of these newer technologies that are really becoming widespread, such as LIT and robotics. And then kind of on the peak is this ability to use augmented reality, artificial intelligence, and spatial computing. And what's exciting is that this curve continues to shorten in each generation. And so what used to take, how many years for navigation and intraoperative monitoring to kind of come to fruition throughout the world, now it's taking a much, much shorter time for this current new technology to spread. And that's thanks to great seminars and webinars like this that we could share so quickly our thoughts among so many people. So when I think about brain tumor surgery and advanced techniques and innovation, what we want is really, how do we preserve the function of our patients and their safety? How do we remove the tumor more precisely? And then can we do it more minimally invasive and improve and keep their quality of life as much as we can? So I'll start first with the minimally invasive kind of idea. I mean, there's no question that as time goes by, we begin to make our incisions smaller. I mean, we do have minimally invasive techniques now to do lobectomies, like we heard earlier. We have port-based surgery now for deep-seated tumors to make smaller incisions. And then perhaps the smallest of all kinds of surgeries would be laser surgery, where we do it now a 2 or 3 millimeter incision to try to ablate the tumor in deep-seated areas. And so if we just look at of LIT, which is laser surgery, it's really kind of expanded in the last 5 to 10 years. And there's no question why. I mean, it's minimally invasive. Like I said, it's efficient, effective, and repeatable. And what more importantly, it allows us to kind of now treat lesions that we may not have wanted to do open surgery on, these deep-seated lesions that are deep in the thalamus, or that have already failed other options, or the patient may be just too sick to undergo a large, long surgery.
Michael, could you switch to presenter slide?
Okay, no problem. Here you go.
Thank you. That's much better. Thank you so much.
Okay. So there's no question that if you just look at PubMed, that there's a large amount of literature that's been supporting this so far. And we've looked at our own work, looking at first newly diagnosed GBMs. And if you look at small lesions and newly diagnosed GBMs, and you select them very carefully and maximize the amount of ablation you could get, you could really actually see quite a good overall survival. And when we compare a cohort of deep-seated thalamic lesions where we either just biopsied them or we actually did laser surgery, there's a trend towards improved survival with these really kind of difficult to treat deep-seated lesions, where we see almost a 7-month improvement in overall survival. For recurrent GBMs, which is perhaps more likely where you use LIT, there's been, again, a lot of literature, too much now that we actually have, pooled analyses and analyses have been published with multiple institutions kind of showing their data. And there has been shown that pooled post-LIT survival now is reaching, over 10.9 months. And I think that's only going to improve as we continue to select and isolate the patients that would do better with this kind of surgery. And this is an interesting study out of Henry Ford, where they showed if they look at recurrent GBMs and you compare LIT, those that are eligible for LIT versus those who are eligible for resection, that there was basically a very similar survival outcome, whether you do an open surgery versus LIT. However, the LIT patients had a shorter length of stay and were able to return to their quality of life much faster, showing again that there is a significant area where we could kind of go towards these more minimally invasive approaches. But what's most exciting about when you think about technology is how we start combining all these different techniques together. And that's really where the synergy will happen. So one example is if you take the robot and you use the laser and you use intraoperative navigation like an O-arm, you can now, we've seen our accuracy improve from like the 90s to now 100% over our last 150 patients by combining technologies to kind of use them synergistically. And as we use artificial intelligence and we start using curved lasers and whatnot, the expansion of where we could use this technology and help the patients to continue to grow. This is just one example of a very challenging patient. Comes in with this almost butterfly glioma. It was a GBM IDH wild type MGMT unmethylated. And we decided to do this with laser because we felt open surgery would have been a little bit risky. So we There was a wispy area in the ventricles and a more solid area in the thalamus. We treated it with laser ablation. We only got like a 60 or 70% ablation, which usually we try to get at least 80%. But he responded very well in this situation. And some of those details are still unclear as to who will respond better than others. But 36 months later, he still had control at the site now with standard treatment, chemotherapy. And then he unfortunately progressed in his spine with a metastasis and passed because of distal metastasis, which is also quite unusual. As we move more towards open surgery, we think about how do you maximize resection without sacrificing cognition, and that's always the conundrum of a surgeon. Is as we've seen earlier, is really trying to protect the patients. And we've made tremendous successes and steps forward with the use of advanced imaging, intraoperative 5-ALA, and then with safer surgery, adding in tractography and functional MRI and intraoperative monitoring. But at the end of the day, we still kind of have fall short in that we are only approximating the tumor and also approximating function. So for instance, when we talk about quality of life, we often talk about motor, vision, and language. And for us, that's a success. If somebody's able to have intact motor, vision, and language, they're great. But as these patients start living longer and longer, their quality of life and their higher level of neurocognitive function becomes critical. And so what about all of these other areas of cognition? So their memory and their anxiety and their emotion and their IQ. How can you tell a patient what is their overall quality of life going to be? So, as we kind of begin using more and more functional MRIs, and we now could kind of use tractography to understand where the motor cortex and sensory cortex, and we can map it out and find these safe entry zones. What do we do when we have a tumor that's wrapped around multiple fiber tracts in multiple areas, some of which we can't necessarily map out intraoperatively? How do we know and predict which ones are critical and which ones we could kind of take in order to get a better resection? And part of the issue is we have some, the information that we've been educated on continues to improve. So, when I was in medical school, we learned about the language system very simplistically, Broca's, Wernicke's, and the arc fasciculus. But more recently, we now know the language system continues to evolve and becomes much more complex. And this is just published in Neurosurgery 2021 from the UCSF group, showing all the areas of the language area network. And if you stimulate each one carefully, how can you preserve them? And some of them you can't even map out intraoperatively. So in addition to just a structural MRI, we need to start talking about, how do we do connectivity and wiring diagrams as we look at these patients. And so we started incorporating fMRI and DTI structural connectivity into our patients to try to look at this, to understand, to answer some of these questions. So for instance, if this is a left temporal glioblastoma, we automatically think of speech and language monitoring and mapping. But I would argue that all of these networks and fiber tracts are important around this tumor. And in some people, it's going to be more important to preserve all of them than others because of their redundancy and how the networks are set up. In fact, when we looked at this in our patients, we found that patients without deficits, 83% of them had a tumor that was involving some major network that would be considered important in that patient and maybe not something that we'd be mapping. Where are we going with this? Well, can we do theoretical neurosurgery? Can we really plan out very carefully what tracks we'll take before we operate and predict somebody's IQ drop before we actually operate on them, predict their emotional status, or can they go back to being vice president after surgery? I'm going to skip this in lieu of time, but we've kind of generated a classification system that now we could actually identify the risk of each tract that may be around a tumor. So for instance, this is a left posterior temporal glioma. It's kind of flipped on the scan here. And we know that there's certain dorsal attention network, the default mode network, and obviously language are involved. And by adding up the scores of how many networks, how many hubs, and how many tracks are involved, you can now kind of put a neurocognitive risk assessment on these tumors that you could discuss with the patient ahead of time and really kind of look at that. And then you could compare pre-op and post-op, as you can see above and below. Below is where we resected and we preserved some of these network fibers by altering our entry site. And we've started looking at this more universally with a large glioma connectome project that we're kind of trying to understand now how to preserve some of this cognitive function, with the goal of eventually, if we can understand all of these kind of networks, can you eventually stimulate them and do neurocognitive rehabilitation in the future and repair some of the lost function long term? So the last area is really just resecting tumors. And we know that the more we resect, the better a patient will survive. However, when we look at the estimates, we still don't really know how much tumor we're actually leaving behind, how many cells we're actually leaving behind. And a lot of this work is based on an estimate of an MRI and an estimate of a post-op MRI, but it really doesn't tell you the whole story. So advanced imaging is kind of an area where preoperatively and intraoperatively will help you guide a little bit further towards where tumor actually is. We know the contrast enhancement is tumor, but when we look at the flare or the T2, is that tumor, is that not? And there's a lot of different advanced imaging coming to fruition. I mean, one of the ones that we use is MR spectroscopy, but we use whole brain MR spectroscopy. So we image the entire brain and we could actually predict. So here's an example of a flare MRI on the left. And the question is where in this flare is tumor and where is it not tumor? And so if we map the entire area with whole brain MRI spectroscopy, we actually could show that using artificial intelligence, where the posterior area here in purple has a very high chance, 85% chance of recurring in 6 months and becoming in contrast enhancing, and the front part doesn't. And intraoperatively, this is critical information for us to tell where to guide this surgery, where to be aggressive, where not to be aggressive, and how to preserve function. Once we're in the surgery, then we take a biopsy. We all take frozen biopsies. This is a technique that's been around for 120 years and really hasn't changed. But there's been an explosion in the last 5 years of a lot of technology on intraoperative tissue analysis. And so there's immediate feedback while you're operating. There's too many to go into in this talk, but the one that we are opting here is use Raman scattering microscopy. And basically, as you operate and you get through the tumor, you could get these images of, it looks like a frozen, but they're actually only take less than 2 minutes. And you could actually get direct feedback as to what the tissue looks like as you're marching through the different margins of tumor to decide how close you're getting to kind of residual tumor. And when you do this 3 million times, you could then feed this into a kind of an AI algorithm. And we worked with Michigan to kind of help develop this and validate it. And now you could actually get the AI to tell you within those 2 minutes, what are the chances of this being a tumor and recurring? So it gives you more direct feedback while you're operating. So now when I'm operating, we have all these technologies embedded into the surgical field, the pathology, the functional MRI, the cognitive assessments, to help guide the surgeon and give them feedback as they're operating. But wouldn't it be nice to see this rather than looking around the room, see it in your headset? And that's really where I think augmented reality is going to kind of come to fruition. We have multiple companies now. We're kind of working with our own idea, but this ability that, first see the anatomy is great, but can you provide that headset where the surgeon could be fed in all this information, not just the anatomy, but the anesthesia information, the flow dynamics, the pathology, the cognition and neurocognitive abilities. And so all that's going to get fed into now kind of this augmented reality headset so that the surgeon can get updated in real time about all these details. So instead of just having this very siloed workflow of, we have the preoperative imaging and we take 1 or 2 of those into the operating room, we have the frozen and some intraoperative monitoring, but we really don't pass much to the neuro-oncologist or the radiation oncologist other than what the pathology is and a post-op MRI. Now you could see how this workflow is going to be incorporating all of this technology. So the preoperative information, this preoperative imaging and neurocognitive assessments will be brought into the operating room and used to tailor the operation. We'll be adding information while we're operating, and then eventually post-operatively, we'll be using that information to help guide therapy, guide radiation oncology. Where did we leave tissue behind? Where is there areas of cognition rehabilitation that we could stimulate with TMS? And then how do you then take that information and find out what worked and feed that back into the next patient so that we're all communicating together in a large workflow? In summary, there's no question that there's a tremendous amount of innovation happening. I think this is an exciting time to be involved in glioma surgery. There's just an explosion of new ideas, new technology, thanks to many of the people that are presenting today. And this will lead to better tumor resection and better outcomes, no doubt.
Thank you, Michael. This was terrific. And in the interest of time, we're going to move on to our next speaker, Professor Jorge Ton, who will share with us the RANO-Resect experience, a clinically validated classification system for residual tumor volume after resection in GBM. Thank you for joining us, Jorge. And you're muted.
So thanks a lot. Thanks a lot, Isabel, and also Sameh for inviting me here. And I'd like to share my screen. I hope you can see it. It's like this. Okay. So on behalf of the RANO Resect group, it's my pleasure to talk about extent of resection glioblastoma and a new prognostic validation system for classification of resection. Actually, these are my declaration of conflict of interest. There is none. And if it comes to the definition of surgical resection, there's a dilemma. You can see here the landmark studies and the definitions they used. Gross total resection has been referred as 100% of the contrast-enhancing tumor is being resected. Others are pleased with 90% of contrast-enhancing tumor. And the main question, first of all, is 90% of what? What is the initial volume of the tumor you are resecting on? When it comes to subtotal, the whole range comes from above 40% to above 80%. So when some people feel 50% is a subtotal resection, others say no, it has more to be 80% of the contrast-enhancing tumor. And what hadn't been dealt with at all is the role of absolute residual tumor volume. So what is left in the patient, and also the implications of non-contrast enhancing tumors, since all of these classification systems only focus on the contrast enhancing tumor part. So this is a very nice nomogram from Annette Molinaro from the San Francisco group, and as well, she still adheres in this paper to the percent of resection. You can see that in between 40% and 80% of the tumor being resected, there is no change in the hazard rate for death. If you are able to resect more than 80%, then you turn it into the positive. If you achieve less than 40%, then you can even increase the hazard of death. So if it comes to the real world, this is a glioma like 60 cubic centimeters, and after resection, there's a residual tumor volume of 5 cubic centimeter, which equals to a remnant of 9%, or in other words, a resection of 91% of the tumor volume, the initial tumor volume. So this is in this nomogram a rather good result and should have an impact on the patient's prognosis. However, if we assume the initial volume would have been 15 instead of 60 cubic centimeter, the same remnant now equals with a resection of 66% only, and this is not a really good result. So the question is, what is more important? Is it important what we take out, or is it not even more important what is being left behind? And if we then ask the next question here, for instance, this is a tumor volumetric analysis, contrast enhancement 2.9 cubic centimeters, but 4 cubic centimeters is the non-contrast enhancing tumor. So if we achieve a complete resection of the contrast enhancing mass here with no contrast enhancement left on the post-op MRI, people would say, okay, this is a very good gross total resection. On the other hand, we've still left in more than 50% of the whole tumor mass. So it is important not only to do volumetric analysis, it's also important to consider the non-contrast enhancing tumor as relevant. And this was the question when we embarked on setting up a new nomenclature for extent of resection, with biopsy being only for tissue diagnosis, no cytoreduction of the tumor volume, partial resection being more than 5 cubic centimeters of residual contrast enhancing tumor, subtotal resection less than 5 cubic centimeter, near total less than 1, and complete resection, no residual contrast enhancement left over. And you can see here the class of evidence from the literature, and only this no residual contrast enhancement left over reached evidence class 2B. Anything else was just expert guessing. And then we additionally talked about supramaximal resection beyond enhancing tumor borders, and the value of this remains to be defined, since there's only class 3 evidence in malignant gliomas. So we embarked on a very large series of over 1,000 patients being recruited from 6 different centers in the US and in Europe. And you can see here the data of these patients. All of them had a mutational analysis, so all were clear glioblastomas. MGMT promoter status is 44% being methylated. And this is the proportion of the resection. So complete contrast enhancement resection was achieved in 51% of all cases. Near total resection of contrast enhancement was in 15%, in 21% subtotal contrast enhancement resection, and a partial resection in 10%. So when we now break down these patients, we end up with 744 IDH wild-type glioblastomas, all being treated with post-op EORTC protocol, the so-called STUP protocol. So we have here a cohort of 744 patients with some surgical procedure, either biopsy or resection. These are the numbers: complete resection 350, and the others, you see 55 patients with biopsy, but all of them underwent the same post-op treatment. And if you then compare overall survival in the different groups, you see that partial resection of contrast enhancement or even subtotal do not make any difference. There's no statistical significance, and you can see median overall survival 16 versus 16 months. The only statistically significant difference was the complete resection of all contrast enhancement with 20 versus 17 months in the near total contrast, in the near total resection of contrast enhancement. This was the only statistically significant difference. And you can see that the near total resection was similar to partial and subtotal resection. So we then embarked on those patients who underwent a complete resection of all contrast enhancement, having the same post-op therapy, and we ended up with 356 patients, and we looked whether or not the residual tumor, also including the non-contrast enhancing portions, is relevant. And we ended up with a threshold of 5 cubic centimeter of non-contrast enhancing volume. And this turned into a real benefit for the patients. So overall survival in the patients who had what we call supra-maximal resection, which means no contrast enhancement left over and less than 5 cubic centimeter of non-contrast enhancing tumor, they ended up with a median overall survival of 29 months versus 20 months in those who had a complete resection of the contrast enhancing mass only, but had some residual non-contrast tumor left. And so we ended up with a 4-tier classification. Class 1 is supramaximal resection, means no contrast enhancement left and less than 5 cubic of non-contrast enhancement. Class 2 is less than 1 centimeter of contrast enhancement and or more than 5 cubic centimeter of non-contrast enhancement being left behind. Class 3 is submaximal contrast enhancing resection, which means anything else more than 1 cubic centimeter of contrast enhancement is within this class, and any other thresholds do not make any clinical sense, and biopsy is no reduction of tumor volume. If you apply these 4-tier classification on this cohort of 780 patients, you end up with a real good differentiation for progression-free survival and even more so for median overall survival, with 24 months in class 1, 19 months in class 2, 15 months in class 3, and 10 months in class 4. And if you now consider that all these patients had the same post-op therapy, then you end up with a real impact of resection in this group, whenever you had any drug which would give you an additional 5 months of survival benefit, it would be immediately be a blockbuster. And remember, we are talking about the residual volume, and we are talking about the non-contrast enhancing tumor mass as well. So this was the resection at first, and now we were interested in whether resection in recurrent glioblastoma matters the same. Again, we are talking about a residual tumor after resection. The first study had been published in 2022 in Neuro-Oncology, and this has been published 6 weeks ago in Neuro-Oncology. So we had 2 cohorts from this first cohort. The one with the resection at first recurrence had 310 patients, and those without resection at first recurrence, 370 patients. You see that the amount of initial resection was similar in both cohorts, and the proportion of MGMT promoter methylation status was also completely similar in both cohorts. So very nice match. When it comes to the resection, we had 50% with RANO class 2, 20% with RANO class 1, which is supramaximal resection, and 30% with RANO class 3. So resection per se matters. The red line is the survival group of the re-resected group, the green one with the non-re-resected group, and you can see there's a statistically significant difference. Also, if you stratify for MGMT methylation status, it's relevant in both. Now, if you compare RANO class 3 in the re-resection setting, you see it does not differ from no re-resection. There's no difference whether you do a subtotal re-resection or you don't resect at all. If you, however, look into the amount of resection, you see that those who had a very good resection, being RANO class 1 or 2, they made a real significant difference compared to those patients undergoing a subtotal resection, RANO class 3. So the median overall survival is 11 versus 8 months post re-resection survival, and this is statistically significant. And it ends up that the amount of the residual tumor volume shows a very close relation to the hazard ratio for death, and this is even an exponential curve. So the more you leave in, the higher is the hazard ratio for death after first recurrence. So the amount of volume matters again. And then if we say, okay, maybe we compared apple with pears, and we wanted to see whether those patients who had a subtotal resection had any bias, any selection bias, we did a propensity score matching, which then excludes all these confounders, and we can match the patients with resection RANO grade 1 and 2 compared to RANO grade 3 with all the confounders like age, tumor size, and other things being matched and comparable. You see there's even a larger difference in favor of the complete or supramaximal resection. So this ends with the recommendation that whenever you see at the pre-surgical planning in your patients with a recurrent malignant glioblastoma, that you will be able most likely to at least resect all the contrast enhancing mass, so have less than 1 cubic centimeter left behind after re-resection, then you should embark for this surgery, but also always, if possible and available, with intraop neuronavigation, not to compromise the function of the patient, in order then he can have some post-op additional therapy. However, if you know in advance that you will not reach that goal, then you should really carefully discuss whether it makes sense at all to put this patient into the OR, and only if there's some symptom improvement from mass refect, also from cytoreductive mass refect, that might be a good candidate for having a surgery even in this respect. Otherwise, you should refer him to non-surgical procedures. So to conclude, the RANO categories for extent of resection in our hands, and now there are coming other work from other departments confirming these data, that post-op tumor volume in cubic centimeter is more relevant than any relative tumor reduction, that supramaximal resection beyond the contrast enhancing volume conveys into a prognostic benefit at first surgery and also at second surgery, and should be denominated as such. We think that these individual RANO classes reflect different post-op tumor volumes and outcomes, which then will be of prognostic value independent of clinical or molecular marker. And as such, the RANO resect categories may serve for stratification and overall design of clinical trials. And the RTOG in the United States now embark on clinical trials, and they already use these RANO resect categories for stratification. And with that, I'd like to thank all our investigators and investigational sites, and thank you for your attention.
Thanks a lot, Professor Ton, for this excellent presentation. I don't see any question from chat box or either from faculty. So we will shift to next speaker, Professor Kate Dortmund. She will talk to us about post-operative and supportive care of patient with glioblastoma. Thank you.
So thank you very much, Sam and Isabel, for asking me to speak. Can you see my slides?
Yes.
So we've heard a lot of really wonderful science and technology up until this point for glioblastoma, but I'm going to shift gears a little bit to something that I think is just as important for these patients. And that's, really the supportive care of patients with glioblastoma. So we know if there's a lot of research that would suggest that patients indicate that their quality of survival is as important to them as their quantity of survival. And so this should be a really important metric that we have in our treatment of patients with glioblastoma. And we also know that quality of survival will depend on a lot of factors, each of which we should be considering. Some of them, of course, are factors that we can't change. For instance, a tumor in an eloquent region, or a tumor that's perhaps unmethylated. But there will be other factors that are modifiable, or at least can be taken into consideration. So patient factors, including their management of comorbidities or their social situation, their resilience, or depression and anxiety, or treatment factors, particularly thinking about having safe surgery that preserves function, radiotherapy that preserves function, and looking at clinical trial options that have less effect on the quality of survival. So how do we put this into practice? Now, a lot of my research has been on quality of life in low-grade glioma, and we know that in multiple domains, we can see here in role function, emotional function, cognitive function, social function, and physical function, and overall quality of life, compared to a normal population in low-grade glioma, there are significant deficits in quality of life. And we know that these are persistent for years. Now, in high-grade glioma, there's also been, of course, a lot of work into quality of life to show that, similar to low-grade glioma, in glioblastoma, no matter which particular instrument you use to look at quality of life, whether you're looking at symptoms like fatigue, depression, and anxiety, or whether you're looking at overall function, high-grade glioma patients have significant impairments in their quality of life. In particular, in high-grade glioma, physical functions, anxiety, and cognitive functions are important, and also the ability to participate in social roles and in activities. I I think the really important thing with glioblastoma is the relentless disease trajectory means that right up front from the time of diagnosis, and this goes a little bit to what Ek was talking about before, you really have to have a coordinated program to make the quality of survival for whatever time the patient has to be the best that it possibly can be. But of course, for many of us, including me here in Melbourne, the sort of single navigator for every patient with a coordinated multidisciplinary clinic every time with people on call may not be possible, but I'll talk about some other options that might be available. So if you're going to have a coordinated program, it's going to look something like this. It's going to really start at diagnosis. And I think one of the things that patients often miss is information about their disease and the timeline of their disease. It's interesting, but if you survey patients, many of them will not know that they have an incurable disease, despite what you've perhaps thought you might tell them. So information about their disease and guidance about what to anticipate right from the time of diagnosis is important. Identifying a support network, perhaps including some spirituality, and by that I don't mean religion, but some sort of spiritual support. Identify and treat medical comorbidities, anxiety and depression, which may also impact on quality of life, and make sure that the patient is receiving excellent medical care. And I think we can't abrogate that responsibility as neurosurgeons to anyone else. I think that we need to be involved at that from the very time of diagnosis. Of course, we've heard a lot about excellent surgery to achieve a safe maximal resection, and that's an important part of improving post-operative and care and survivorship care. But as well as high-quality surgery, high-quality nursing, and also the ideas of bundles of care or enhanced recovery after surgery paradigms to standardise good care, post-operative care for the patient is really important. And of course, symptom management during adjuvant therapy is extremely important, particularly around radiotherapy and chemotherapy and the symptoms that may come with that. But then once the patient passes their acute treatment stage, we move into a survivorship model. Where we should be identifying factors that might be impaired in the patient's quality of life. And so quality of life should be continuously assessed. And we'd be looking at neurocognitive factors, fatigue and sleep, pain, anxiety and depression. And these things can be easily assessed in the clinic, perhaps just with a questionnaire before the patient comes into the office, and then can be addressed where possible. And of course, we should be treating these factors that impair health-related quality of life, whether these be neurocognitive rehabilitation, exercise therapy for fatigue and for sleep, mindfulness, managing sleep and pain, or resilience training. And then, of course, at some stage, we'll move into end-of-life care. And I think one of the things that we don't do well is to have patients referred for palliative care early in their journey. That's often because patients feel that, or even their treating doctors feel that might be too confronting. But I'll speak a little bit later about the benefits of early palliative care to lead the patient care, but probably right from the time of diagnosis, which is when we're currently referring to palliative care. One of the other important things, which probably I shouldn't put in the end of life box, but should probably go right up the front, is also addressing the needs of caregivers. If caregivers have poor quality of life and poor survivorship, then the patient will have poor quality of life. And so caregiver training and caregiver support is extremely important. The patient should have excellent symptom management and should have open channels of communication with the treating team. Patients feel very abandoned if at the end of life they can't contact their treating team. And so having some sort of a brain tumour specific support network linked to their hospital is extremely important. So just talking about palliative care, it's well known now that patients who are referred to palliative care early will actually live longer. And I think this is a message that we need to get across to our patients. And if you have palliative care services available, they should be engaged very early. There's a number of studies that would show that patients live longer because of the excellent symptom management. And so perhaps emphasising this with patients, that this is not just end-of-life care, it's supportive care, it's symptom management and early referral, even at the time of diagnosis, if the patient will accept it. Sometimes, of course, that's a little bit difficult. The patients may not accept it, but I think with the right narrative given around the referral, early referral is really important for glioblastoma patients and will vastly improve their quality of survival. There are a number of symptoms that are and syndromes that are here that you can see that are really account for about 40% of the reduction in a patient's quality of life. It's often interesting to neurosurgeons that we think that speech disturbance, physical limitations, perhaps other physical symptoms might be the most important determinants, but in fact, cognitive dysfunction, whether real or perceived, anxiety, depression, fatigue, and sleep disturbances account for about 40% of a reduction in quality of life. So how are we going to manage this in a busy neurosurgical outpatient clinic, and what is that going to look like? So we've done quite a lot of research, given that we have limited resources, into how we might be able to manage this online, with some sort of online platform that our patients, many of whom are scattered all throughout the large country of Australia, very far from the hospital, how we might be able to provide supportive care for them. We've reviewed online interventions for cancer patients, and found actually that there's very little research around this area, and most people design an online intervention and never really assess it appropriately or evaluate it. And if it is evaluated, often it doesn't have any effect, which is what we found in our systematic review. And so we've actually surveyed 200 of our own patients to see what they would like if we had some sort of an online supportive care platform. And these are what the patients tell us, that they want to be able to control the amount and type of information others know about them, but they want to be able to connect with people online. Obviously, they want to be able to use some sort of a supportive platform online at any time. They want to use it as a guide or filter for useful information. Patients find Google extremely confusing. They don't know what can be trusted and what can't be trusted. And this is a really important feature that they want out of any supportive care information that we provide. They want a health professional to moderate or contribute. And they want the ability to share experiences with each other. They want to provide their own supportive network with others in a similar situation, which is often quite hard for them to access. So we're just going into testing mode for our own online supportive care resource. It's been developed with our patients as a co-design. So they've designed the logo, the colours, the everything. It's a 3-pillar online supportive care platform with a learn pillar, which is a curated information pillar with trusted information for patients, which they can search for their stage of disease, tumour type, stage of life. It has a community pillar where patients can connect with each other in a social media type platform, but moderated and in a safe space for them. And it has a toolbox where patients can use. One is a carer training metric program, and one is a cognitive behavioural therapy program for sleep, which we'll test to see if we can deliver online with effect. So hopefully this supportive care platform online will solve some of our problems for resources for supportive care for our patients, which I think, of course, is just as important as the excellent surgery and other adjuncts that we use for these patients. So thank you very much for listening, and thank you for inviting me to talk.
Thanks a lot, both. Professor Drummond, for this excellent presentation. I don't see any questions, so we will shift to our next speaker, Professor Manfred. He will talk to us about current research burden to improve glioblastoma treatment. Thank you.
So can you see the slides?
Yes.
Okay. So I go to presentation. So to round this up, it's always some science. So I call this frontiers. And there are a lot of things that are emerging right now. And I want to concentrate on 4 issues: the circulating biomarkers and signaling, cancer neuroscience, brain metastases, and tumor immunology, because it all comes together. It's not only for glioblastoma. So for biomarkers, I think that for biomarkers, there are a lot of different things that you can draw out of the blood, like circulating DNA, circulating tumor cells, or EVs. And I'm going to focus on EVs, extracellular vesicles, which I think are very good to study because they are really information packages. These extracellular vesicles, when they're in the circulation, they are really the summary of what's going on in the tumor, because they are sort of the means of intercellular communication. So it's what's produced by the tumor cells and the reaction of the microenvironment to that. And all this can be potentially found in the blood. And all these EVs that are disease associated will only be partially be from glioblastoma. And this is something that I will show you at the end. So when you do a liquid biopsy, as we would call it, as I said, there is cell-free DNA, RNA, circulating tumor cells, and all kinds of things in there. But we would like to look at these extracellular vesicles, which can be correlated to clinical findings and which can be correlated to other molecular findings like the proteomics or methylome analysis. These EVs, they are small packages that contain proteins, microRNA, DNA, and mutant DNA. So they can be used as biomarkers, but they are also to be studied because they really relate to a lot of information which is passed on between cells as intercellular communication. So when we isolate these EVs, you can look at time courses, see what's happening preoperatively, postoperatively, or in follow-up, and see whether there is any dynamics in this. Now, first it is that, of course, you have to see whether you get a signal, and just looking at total EVs that can be isolated, there's a highly significant increase in EVs that can be drawn from the circulation. Patients that have a glioblastoma compared to patients that have more low-grade tumors. When you look then at post-surgery, what happens is that these EVs go down within a day and a week. And this would be the dynamics. They're very fast. So when we look at biomarkers, that is something that really tells you something about what's going on in the tumor and the reaction of the body to it. It's also interesting that the EVs that we can isolate are correlated to the flare, most likely much more to the flare than to the contrast enhancement. And this is something that is actually interesting because it's also correlated to survival. When this is, I think, a very strong correlation, which we published some time ago already. So when you look at patients that arbitrarily we take a number and say, well, as of this number, we call them high EV count, and other number, we call them low EV count. The overall survival is significantly different between those. So that means that if you have a lot of flare, which means a lot of high EVs, a lot of EVs will reach a high EV count, and that probably will influence the body because these EVs are a means for the glioblastoma to manipulate the host microenvironment or the host systemically as well. But they can also be used to study the biology, and that's why I think where research is going, because the topic was what are we going to do for research and in the glioblastoma in the future. So if we isolate these EVs from cell cultures, for example, and we use these EVs to co-culture them with other cells, and then we can see what the interaction is, what the intake is, and what the kinetics are. And just very simply, these EVs, they do contain signaling molecules. This is the pretty dish that is covered with PD-1 ligand, and this is the positive control. And if you put the EVs on this, they actually bind to that because they have PD-1 ligand in it. And if you block this with anti-PD-1, then you can inhibit that. So they do have an immeasurable influence on the tumor environment, and this time, which is immunologically relevant. But also, when you look at this in vivo model, there's a tumor that is implanted into this mouse that is GFP positive. So, and it also has another fluorochrome in it, so we can actually isolate the EVs from wherever we look in the body. And it was found that in the lymph node, in the cervical lymph node, there was EV material there. So these EVs, they go long distance, maybe through the lymphatic system, and they may be able to manipulate the host immune environment. And the cervical lymph nodes are something that's becoming of great interest also in other clinical trials. So there's another proof that there is most likely intercellular long distance communication coming from these EVs, and we just need to study that. These EVs have a great influence on immunomodulation. There's this very great, it's an excellent review by this group. So there are a lot of molecules that can be found in immune-derived extracellular vesicles that can cause immune activation, but also immune suppression. And this is from immune cells, and this is from tumor cells. So these cells sort of connect via EVs and they're signaling vice versa. One can potentially construct EVs and use them for therapy, for immunotherapy, but also for other therapies. We can use them for prognosis to see whether specific molecules are correlated to prognosis. And this, I think, very nicely demonstrates, as taken from the same review, that the immune cells really interact with each other through EVs, not only through cell-cell contact, but also a cancer cell, in this case, in our case, now a glioblastoma cell, would manipulate all the different cells, particularly the T cells in the tumor, to change their behavior and manipulate them, and maybe even induce immune tolerance of the tumor. The question really is, though, when we look at the EVs that come from a tumor, we don't know really where they come from, because they can come from very different areas, and they're very different microenvironments. So they are really a whole soup that is produced by the tumor. But that has to be taken apart. And if you then look at all these EVs that you can under the microscope, how many are actually from a relevant the tumor cell that gives us some idea about the tumor biology, that is hard to say. But the whole, these EVs go down, and this is what we want a week pre-op. But the question is, which are reactive from the microenvironment to the tumor EVs? If we would be able to have the tumor EVs isolated, we would get a great amount of information. This is from isolated EVs from tumor cells in the Petri dish. So this is the tumor tissue, that's a methylation profile, and this is from a cell, and this is from the EVs. So it's really a fingerprint. You get really a genetic fingerprint in these EVs. We first tried to use tetraspanins. These are these CDs, CD81, CD9, and CD63, which are highly expressed and overexpressing glioblastoma cells for purification, but that has not really gotten us anywhere. Now we're looking at telomerase modifications, in an in vivo model, at least with a tumor implanted that has these markers in there, we can at least distinguish between cells, between EVs that are from the mouse and that are from the xenotransplant. But if we then look in the blood, you see that there are very, very few. This is just a dose response curve for spotted plasma, but we really have far to go to really have big quantities that we can isolate and work with. So this is work in progress. But when we say what are the research strategies nowadays, these are to isolate EVs And we even tried with nested primers to enhance the recovery. It looks a little better here. You can see that, but very few spots only there. So this is work in progress. The one thing that may help us in that context, that's another big step forward in tumor biology, is the deconvolution of DNA, which is put forward by this group because you take particular signatures, DNA methylation signatures from proper tissue, and then if you have a mixture of tissue, try to infer by biomathematics how much of your desired signature you have in there. And we can at least see that for the glioma, for the neural signature that we attribute to these gliomas, we do get some signal already, but this is biomathically still a long way to go. So EVs may serve as biomarkers for clinical purposes, but their biological role is that of signaling in paracrine and long-distance intercellular communication and modify our tumor microenvironment. Now, the next thing that I think is very big, will become very relevant in the future is tumor neuroscience or cancer neuroscience. This is a very nice work done on brain metastases. And the only thing I want out here, point out, is that for the difference between brain metastases and extracranial metastases, that there seem to be neuronal metaprograms included in here. So there seems to be a mimicry towards the neuronal environment. And again, in metastases, Doug Hanahan has shown that when you look at the normal environment, there's an astrocyte that sort of sits beside the communication between nerve cells, the synaptic cleft. But they found that also metastatic cells, they just sit there and participate on what's going on in the synaptic cleft and benefit from that and take up the signaling, and actually by changing their cellular signature, behave as if they were belonging to that. And this has really real consequences, because those patients that have, this is in the case of an NMDA receptor, a glutamate receptor, this is really correlated to survival. So those cells that behave more as if they were belonging to the brain can really relate to what's going on in the brain, do better, and the patient consequently does worse. And they even proved that in an animal model, that when they influenced, or when they modified the cells to express those neural genes, they were more prone to develop brain metastases. So this would be the picture. There's this nerve cell communication, the neural communication, and the tumor cells take part in that. And it's also the gliomas do that. So it's not only tumor in general, but it's really highly relevant also for the glioma. And this is from Michel Monier's work. And there are all these different mechanisms. One that is potentially very important is adaptive myelination that takes place over long distances. So this would be the picture for a glioma cell. There's this neuronal communication, but there are molecules that are sort of secreted by this neurons, but there are also soluble factors, cleaved factors, and direct communication. And all this contributes, if the glioma mimics a lot of those cellular characteristics, to the survival benefit. And this is not just something taken out of the air. There are already clinical trials running that sort of embark on this kind of tumor neuroscience interaction in the real world. And another group that is very interested, very good at that, is in Heidelberg, Wolfgang Wick and Frank Winkler. Again, this is sort of the depiction of what's the research area right now for the gliomas. It's this direct neuronal tumor interaction, but it also holds true for this paracrine bystander benefit that the melanoma or the metastatic cells take out of that. And what they found is that there are two kinds of glioma cells, glioblastoma cells, those that work and migrate and infiltrate the brain, and those that then connect, become stabilized, and also connect to the central nervous system. So once you have established that kind of network, you have a tumor that is very resistant to therapy, and all this is based on neural glial communication. So we have a new dimension, which is axonal and microtubular connectivity of the tumor cells with the brain, which is, of course, will offer new dimensions of therapy, but it's also a new dimension for biology. We have embarked on that too, but not really in genetic fingerprinting, but the methylation, which is epigenetic fingerprinting, showing that for some time already that the different subclasses, RTK subclasses, have a big influence on cellular behavior. But again, I can come back to this word of deconvolution. So this is just in progress. This is the paper by Moss about it's all biomathematics really. And by taking huge sample sets in an international collaboration of 4,000 tumors, they try to get our group and this whole work packages try to get a neural signature. At that time it was called neuron fraction, but now it's called neural signature. And you see that between the CNS tumors, there are some less differentiated and some highly differentiated that have really a different amount of this kind of neural signature based on biomathematical deconvolution of the gene methylation patterns. And what is very interesting is that for example, the IDH mutant tumors, they behave a lot more, have a much higher signal and neuronal signature or neural signature than the others. And those are the ones that, of course, are the ones that more intrinsic to the brain and more epileptogenic and all kinds of other things. So this is for another subgroup of tumors, the H3K27 mutant midline gliomas. Again here, high signature versus low signature gives you a significant difference in patient survival. So we do have a molecular marker that tells you something about the integration of these tumors into the brain that gives them an advantage. And in the whole big series here of 5,000 patients, this is going to be submitted this week, this paper. You see again that the more tumors mimic neural behavior, the worse the patients will do. Initially, it was called hijacking. I don't like the word hijacking. I think it's called more like a mimicry. Just as a small part of that investigation, when we look at the soluble factor that is produced, the BDNF, see the same thing, that there's a significant difference. Here's survival difference with those patients that have high serum BDNF and low serum BDNF. So the more neural, the worse the outcome, because these neoplastic cells that are sort of mimicking the brain, they feed with their EVs and with their program and with their connectivity into all kinds of cellular programs which are relevant for tumor interaction, tumor survival in the brain. So that is really the picture that's sort of emerging. There's the neuroscience of cancer, and the neuroscience of cancer is not only for metastatic tumors, but it's also for gliomas, because the interaction with these neurons sort of triggers a lot of survival programs in the cells. So there's interaction with the cancer cell and the immune cells, with the immune cells amongst each other, and also with other transmitters, even with serotonin. So I think that the next thing we have to understand is the immunology, and I'm finishing with that, because we do seem to have for patients, we saw this neoadjuvant PD-1 therapy, which was published, which we actually, many people have adopted now, and there's a survival benefit. And the idea was that if you do it neoadjuvant, then when the tumor is in a situation where it's still present, the immune system can see it, and when the immune system can see it, it can mount an immune response. This is our survival curve as far as we have it. So we have some 5-year survivors patients now, but we have to understand, and this is what, again, the new frontier, what is the difference between patients like this, where you have this recurrence or this residual with PD-1, and then it just goes away. And this is now a 5-year tumor ruined or residual that's probably just a scar that's left behind, and those that within weeks blow up in your face. So there are extremely differences in these patients, and we have to understand that. So when we have to look at the tumor microenvironment in the immune section, if we look at it from the tumor cells, we see that these in the patients, that there is a very specific anti-PD-1 signature in the tumor infiltrating lymphocytes. when we look at the lymphocytes in the periphery, we see that there is a peripheral T cell response, which is a highly interferon gamma response. So we have to work that out, begin to find out why do these tumors work that way, and what is the predictor for an immune response in this. So I think to get to new frontiers, it's the role and potential of EVs from tumor microenvironment, the role and potential of neural mimicry, and the determinants and potential of specific immune interaction. So that is sort of a run through from what I think is important for research at this point. Thank you very much.
Thank you, Professor Manfred, for this excellent presentation. Is there any question from panelists? Thank you. And now we have reached the end of this session. Is there any final words from anyone? Okay, thank you all for joining us today, and I hope you have enjoyed as we have enjoyed a lot to gain more awareness about glioblastoma, and we promise we will make more projects about this interesting topic.
Yeah,
thank you.
I think next time we have to do more advertising.
Thank you.
We only had about between 40 and 50 people who were listening. So maybe next time we try to get 1,000. Wouldn't that be a goal? Okay, bye bye.